Hey everyone, welcome to the Func Med Nation podcast. I'm your host, Dr. Steve Noseworthy. The views and opinions expressed by my guests in this podcast are not necessarily consistent with my own views and opinions. However, I do my best to be respectful of their views and opinions as they express them, even if they differ from my own. Now let's get to the podcast. Okay, so let's go ahead and dive into this. This is, honestly, I've been waiting for this conversation with bated breath ever since we said goodbye on the last call. And just to give anybody listening a little bit of grounding, we've already posted 2 pretty lengthy interviews that I've done with Peter and Rob. And my hope today, guys, is to have more of a clinical conversation. I have posted both of our 2 prior interviews on both the Func Med Nation podcast as well as the podcast, The Inflammation Nation, which is the general public. And I'll probably do the same thing because even though I want today to be more technical and more clinically oriented, I think it's important for the general public to hear your name, see your faces, and know that there are doctors out there that are thinking and operating at the level that we're going to reveal and share today. And the topic is immunoception. And then, as I had mentioned to you guys before, I want to start with a quote from one of the papers from Kevin Tracey, who's one of the big names behind immunoception research. And the quote it's from a 2018 paper in Annual Reviews in Immunology. And it goes like this. It says, the nervous system regulates immunity and inflammation, the molecular detection of pathogen fragments, cytokines, and other immune molecules by sensory neurons, generates immunoregulatory responses through efferent autonomic neuron signaling. The brain integrates neuroimmune communication, and brain function is altered in diseases characterized by peripheral immune dysregulation and inflammation. And there's so much just in that quote, right? There's just a ton of stuff right there. But I want to open it up with a question and pose it not rhetorically. I really would like your opinion and your answers. But why is it that we as clinicians so readily accept the brain's role in controlling visceral function, like the gut, the pancreas, and so on, and even to a certain extent, the hormones, because we recognize, for example, the adrenal system is the hypothalamic pituitary adrenal axis, and that tends to get forgotten, but it's still there. Why is it we have such a hard time recognizing or even accepting the idea that the brain controls and regulates the immune system? Like, it's almost like we treat the immune system as something completely different, almost a foreign entity. Why is that? Why do you think that is?
Well, I'm going to say, first of all, I don't think that, like you said, people are really thinking that much of the brain regulating the gut. I still think people, aren't thinking that way. I just did a lecture down in the Dominican Republic, and I had 2 other doctors. One was a functional medicine pediatrician and pretty good. And the other one was a neurologist who was a neuroimmunologist. And, she did a whole presentation on autoimmune encephalopathies and, really went through it in pretty good detail. Although it was the more severe type things and things that could clearly be measured in the cerebral spinal fluid. But everything, both of their perspectives were that there's a problem in the gut, that this leads to certain issues that lead to inflammation. Inflammation comes up and affects the brain, and the inflammation in the brain produces a bunch of symptoms. So it was purely from a standpoint of going up. And that was the neuroimmune piece. And one of the things I think that we like about Kevin Tracey's work is he's one of the first people to come out and talk about the brain coming down and actually regulating and being the initiator. And I think there's so much, like you said in that quote, about that, in the periphery, in the peripheral sensory nerves, just like we pick up pain and inflammation. So when we have inflammation in our body, in our joints, we feel it in our brain. That also there's immune signals that travel similar pathways that get to the brain, and then the brain is going to respond from a top-down standpoint and have some regulation. And I think, Peter and I have gone about through this because, the immune system is incredibly complex. Right. And as we discuss it, and, there's some really good people and they really describe how everything is. And it doesn't seem like anything's missing from that piece on the overall. And so I think that's the thing is that, the immune and the immune communication within the immune system is pretty well documented, even though there are gaps that we've picked up on. And so I think it's easy to get lulled into the thinking that the immune system operates completely independent and that it may create inflammation in the body that affects the brain, but there isn't, I think, very many people that have the knowledge of the neurology to understand the downward influence and control that the brain has from the brainstem and from the brain itself. And I think that's where the gap is.
Peter, what's your opinion on this and your feedback?
Yeah, well, one, keep in mind that the psychoneuroimmunology community has only been around, I think maybe at best, not even 30 to 40 years. Okay, when they really started, Richard Adler and a couple of those people really started looking at this. And so, for the longest time, these super systems, they've referred to that in many papers, like the immune system in the right hand and the nervous system in the left hand were just separate of each other. And now obviously, like Kevin Tracey points out, that we now know, and I remember Rob and I were sitting in his house a couple of months ago, looking at that same quote and saying, okay, hey, we're getting the toll-like receptors talking to the brain. We got these cytokines talking to the brain. We got these chemokines, and for a long part, of classic education, no one was really talking about. They were just saying, okay, these are these inflammation or these inflammation aspects of inflammation, or these ways that we're telling the immune system to do this. But as Rob's pointed out, it's like, who's the conductor? Like who's signaling to the immune system to do this? And I think that the biggest thing is, I came across a new paper a couple days ago where it's probably a 2019, 2020 paper, I think, that was now looking at the role of the brain in the innate immune system. Okay. And they're actually were studying frogs and looking at actually taking frogs and separating the brain to try to figure out, what happens if they disconnect the brain to the immune system and they put it, they were using E. coli as the antigen to see what happens. And what they found out that was if the brain wasn't present, they wouldn't get macrophage differentiation. Okay. That there was no way the macrophages would actually maybe split to an M1 position or M2 position. And so, there it is. And the paper was talking about how we've studied, a certain amount of the brain to the adaptive immune system, but we really haven't begun to really explore the role of the brain in the innate immune system. And I think that's where you talk about where the literature is going. I think that in the immunoceptive world, I think that's what we're trying to understand now is more of what's the brain's role on the immediate immune response to recognizing the different toll-like receptors, recognize how's that signaling to the natural killer cells, what's that telling the macrophages to do, but trying to understand what particular anatomical areas. And I think the major thing that we're going to be looking at over the next couple of years that gets lost in some of the translation is Kevin Tracey's whole idea of the immuno homunculus.
Yeah.
Okay. And really beginning to look at these definitive areas in the brain. We've talked about a sensory homunculus, a motor homunculus, but now can we actually begin to fully put that together? That's a hypothesis that he put together about 10 years ago. And I think now, we're trying to unravel that more.
Yeah, let's hold on to that one because I think we need to work our way towards that. But, for clinicians that are listening, they'll remember back in their early training days, they learned a little bit about sensory homunculus and motor and how we have these maps of our body up in the brain so the brain can understand, how to connect to different pieces and parts. You use the word immunoception. I'm going to ask you in a second to back up, but I want to share with you, I did a webinar for Vibrant Labs probably 3 weeks ago. And the topic was an effective clinical model for complex disease, complex clinical cases. And I shared with Vibrant and all the people that were listening the clinical model that I use. And this is going back to what you were just saying about the brain is the top dog and everything is interconnected. And I started by quoting Tomio Tada, who was the guy who coined the phrase super system back in 1997. And so I put up a graphic that showed the brain, hormones, and immune system, started drawing these connections. And even now, like going back and looking at that, it's very easy for me to draw out and to map out connections on the neuroendocrine side, right? It's easy for us to even kind of dissect the brain, so to speak, and look at the lobes and look at networks and how things interconnect. But the part of the diagram that represents the neuroimmune interactions is kind of sparse, right?
Yeah.
And you know, I'm certainly no expert in this area. I think I know a little bit more than the average clinician, but I'm no expert in this field, and I'm struggling to put that to fill in that side of the graphic. And I'd be happy to share that with you guys and get your feedback on it. I would love your feedback, actually. And maybe I'll put a link in the episode description that people can, you know, go to the web and look at that. But it's so, as clinicians, it's so helpful to have a roadmap, right? And what I'm hearing from you is that maybe this is where the research is going, is just like we have a roadmap from the brain to the motor system. We have a roadmap from the brain to the visceral system and so on, that maybe we'll have a roadmap to the immune system, right? So pausing that idea, and I'll toss this up for either one of you guys, define interoception, contrast that to exteroception, and explain to us, why it's so important for the brain to understand and have an interface with both internal and external environments.
Well, interoception is really the ability for the brain to perceive what's happening in the body, really from a homeostasis standpoint, right? And this is really critically important because from the time a child is born, and we know that right hemisphere is active, more active in the first 3 years. So when the child is born, non-verbally, they need to be able to perceive and express to their parents or caregivers, you know, when they're in pain, when they're hungry, when they're thirsty, when they're cold, when they're hot, when they need to be changed, you know, or if they have gas or something going on in their stomach, when they're tired. And smell and taste are very much around this, right? So we need to be able to feel those things or sense them right from the beginning for survival, right? To be able to know when something is wrong, when we need to eat, when we need to drink, when things are too hot, if I'm in pain. All of that really is registered in the right brain, and all of it is registered primarily in the insula on both sides, but finally in the right insula, and the right brain is online, you know, early on in that reason. And we need to be able to do that because obviously, again, as the brain is maturing and as we're building from the bottom up, whatever little seeds start in the brainstem as the precursors ultimately grow up and create different areas of the brain, so then the brain can come down and regulate everything. And that's the way, you know, it's supposed to work. That's the way this whole complex system works. We need to have, this kind of internal map of our body, and proprioception, the ability to know where our body is in space and feel our body, and creating these sensory maps is also starts in that insula area, so that all of this kind of is in that area there, and it's very important. And so, you know, it makes sense to us. We think about this, but we don't think about, well, what does that look like? Meaning, what areas of the brain are registering this? As you said, what are the networks from the bottom up that transmit this information. I think there's a lot of overlap with the neuroendocrine, the neuroautonomic system, and the immune system. Because if you hear what Kevin Tracey said, he said basically these efferent top-down pathways through the autonomic system. So through the balance of the sympathetic and parasympathetic, that's what regulates the immune system. And I think he's done a fairly good job of even talking about the input from the sympathetic and parasympathetic into the actual immune tissues and how it actually, may start the process of what's going on in the lymphatic tissue to, start this process. So we do have a fairly good map of this from both the afferent and efferent pathway. But interoception is really critical for that, because also all of our right brain emotions and most of our emotions are built on top of that. So first we sense things, and then we start to sense feelings that are superimposed on those. And then we're able to read those same things on other people. And that's the foundation of nonverbal communication and socialization, and ultimately emotional regulation and attachment. And then that leads to the desire for verbal communication. So this whole idea of being able to, survive and be around other people, and all really starts with interoception. And what we see is that, I think, is the biggest piece missing in severe autism, in nonverbal autism.
Peter, I think that you and I probably have the same mindset on this. And in fact, I was just in San Francisco last weekend teaching our brain chemistry course. And I really made a big effort to try to change the framework, like the conceptual framework of the docs that were there, and not just go through the standard material that we presented for 15 years, but do it, kind of in light of some of the work that you guys are doing, and attach it to developmental, neurodevelopmental issues and so on. And so with this concept of interoception, which is immunoception is one component of that, like some very common clinical manifestations of interoception would be, someone having their blood sugar drop and then triggering some kind of an anxiety event, right? And I don't know that there are many clinicians that make the connection that it's actually the brain that's causing all of this, right? They think, well, it's an adrenaline dump and that's why, but really still it's, it's driving in the brain. So we have all kinds of different types of interoception. Rob, you mentioned a whole bunch of them, like, hunger and thirst and temperature and all these different things. But we also have these chemoreceptors that sense the constituents of the blood, right? Glucose levels, hormone levels, all this kind of stuff. And now, so let's focus in on this concept of immunoception, Peter. And I know that this is like your deal. Like, of course, you're a more well-rounded, you're not a one-dimensional clinician, but this seems to be like a passion project of yours, is to really understand immunoception and bring that into the world of functional neurology. So define it in maybe more discrete terms than what we've defined so far. And what I'd like to get at, Rob, you mentioned that this happens, it's mediated through the sympathetics and the parasympathetics. Like where, and you also mentioned the insular cortex. So where does all of this stuff happen? Is it a discrete network? How highly organized is this system? How predictable and reproducible is it from one person to the next? That was for you, Rob. I'm sorry. Sorry, Peter.
Go ahead. Well, I mean, I think for starters, the challenge for me right now is trying to figure out, like, how do we measure some of this stuff, right? How are we measuring the different relationships of the immune system? I mean, I think that's where, I'm looking at, when I'm looking at a client, you can obviously see like sickness behaviors. You could begin to see how people are, perceiving their reality of their, somebody with anxiety or somebody with depression, or somebody comes down with a cold and they adopt these behaviors that, I'm feeling sick today, I'm going to go lay down, or I feel, once we have these things where we always say like, oh, I feel like I'm getting a head cold. Okay, well, how do you feel that? Well, that's the whole idea of what interoception is, and this immunoception component of it is that I'm getting these signals that are coming from my body, or I sprained my ankle. Okay, can you sometimes you don't have to just look down and see that your ankle is swelling, but you actually can perceive that, hey, I'm hurting, I'm feeling pain. And so I think that trying to get patients to understand that one, when our immune system turns on and begins to activate, it's going to go through these very stereotypical responses. And I think that that's where some of the immunoception research is going, is that we have these very specific responses that the immune system makes, and makes it in a very stereotypical way, very much like our motor system does. Like, we have our motor system that does these particular outputs that are somewhat reflexive, okay? Or we know that they're reflexive, and then over time we can build a complex motor task, and that in itself becomes a very learned response. So I think that that's what we're seeing in the immune system, is that we're now seeing this choreography that happens within the innate immune system and the adaptive immune system, where when we engage ourselves in a certain type of response to maybe a pathogenic response, or we're dealing with some damaged tissue and we're getting a damp response, that we're going to have this very specific response that the immune system is going to coordinate using a various amount of cells that are in the innate immune system, or calling on the adaptive immune system. But then what happens is that then the immune system now makes this memory of it. Okay. So that way, when it happens again, we now can mobilize much faster. And this is not necessarily like talking about our adaptive immune system and our antibodies being made. We're talking about the choreography of all the responses of the immune system that happen to that given moment of tissue damage or a pathogenic response in that aspect. And I think that's what we're beginning to figure out about this whole concept of immunoception, is the idea of how it's all choreographed. Okay. And how you're seeing, what cells that are coming online at certain moments. And I think, back to how we do things in movement, we know when we go to move our body in a certain way, we know it's going to involve our cerebellum, and what parts of our cerebellum, and our basal ganglia and our frontal lobe. So now, when we encounter a certain pathogen or a certain inflammatory response, we're going to get this very stereotypical choreography of the immune response. And then the immune system is then going to, in the insular cortex, going to have these kind of like files that they have now, and they know that, okay, we do this immunologically when we encounter this. And that's how I'm looking at explaining the concept of immunosception.
Right, and you and I did, just the two of us, we did a couple of interviews on one of the podcasts, and we talked about, we used the word engram, right, which is that brain's memory of some kind of a peripheral immune event, whether it's an injury or something like that. Rob, are those memories stored in the traditional way that memories are stored? Or are they stored in the insular cortex? Is this a completely, because it's immune-based memory, it's not like cognitive memory. It's something completely different, but it's memory nonetheless. So is this interlinked with, or is this completely separate from our, let's say, our traditional memory systems?
I think it's within our traditional memory systems, but remember, we have different memory systems between our left and right hemisphere. The right hemisphere has more of a subconscious, unconscious memory, where the hub of it is really around the amygdala, which is really more of an emotional type of memory or experiential memory. We remember what something feels like, but we don't recall it as a memory. Whereas factual memory, episodic memory, declarative memory, conscious memory is really generated more through the left hemisphere hippocampal networks. So I think it's within those systems, but I think like most right hemisphere memories, it's implicit, it's subconscious. It's not something that we consciously say, oh, this is a memory, but our body responds to something as a memory, meaning we know that it's there, like we've been hurt once before. That's what happens in trauma. Trauma tends to live in that right brain. And even though people may not remember the memory of the traumatic event exactly, that it can get triggered over and over and over and over again. Or if they have a memory that's literally a flashback where they literally go back to that moment. But, one of the things that I think is cool is, again, with the interoception, you ask what was important about that. Well, again, that and the insula and the anterior cingulate is where we become embodied, right? That's where we become an individual person. We become self-aware. One of the most unique features of human intelligence is self-awareness, right? Meaning that Homo sapiens sapien, the wise man that knows he's wise. It means that level of self-awareness is what is unique to human intelligence. Right now, we don't ever believe artificial intelligence will have that, but that's the fear, that they may someday become self-aware, right? But without a body, the belief is you can't become
you can't be embodied if you don't have a body. Yeah.
Exactly. And you can't be self-aware if you don't have a body, and you become embodied in that insula. And that's where you recognize yourself from other. Around 2 years of age, a child suddenly recognizes themselves in a mirror. Now, if we look at autoimmunity, what's the concept of autoimmunity? When the immune system loses the ability to recognize self from other. So where would the memory of that or the concept of that be regulated in the same area that we understand our self from other? As a body, we also understand our immune system from self from other. And so you look at that and say, if there's a dysfunction in one, when you have lack of interoception, you also often see, this very high level of autoimmune reactions, eczema, food sensitivities, PANS or PANDAS reactions, autoimmune encephalitis. And all of it is really related to that regulation of those things.
So if I heard you correctly, the right brain, and you've said this many times in your interviews, that the right brain develops preferentially, right, in the first 3 years of life. It's not that the left brain doesn't develop, it's just the right brain develops more efficiently and faster. And the right insular cortex, and I would imagine to a certain extent the parietal lobe, because they would have to communicate together to have this sense of self. What I'm hearing you saying is that has influence over what we would say from a functional immunology standpoint, the concept of self-tolerance. And when we lose self-tolerance, we start to generate autoimmunity. So what I'm trying to ask is, how predictable are these relationships? Like the right brain controls or generates tolerance, and when we lose that, we lose tolerance, and we have the expression of autoimmunity. Is that always a right brain or right hemisphere function? And if that's true, what is the left brain responsible for? And again, back to a question I asked before, how repeatable and reproducible is that from person to person? Is this part of our developmental blueprint, meaning that it's predetermined that those parts of the brain are going to control these aspects of the immune system? Or is that much more experiential, like developmental from the standpoint of, as I have lived and experienced these inputs into my system, my immune system and brain have developed this relationship, and it might be different from somebody else's?
I think personally, because the insula is online so early, these are all developmental. So even when we talk about the right brain and the left brain becoming the right brain and left brain, it's almost all experiential. It's almost all non-genetic. That's what makes the right brain, and the left brain, the left brain. The timing of it is what makes the difference, right? And I think it's very, very predictable. But what we often see is that when something alters that timing mechanism, it may alter how the brain is developing and regulating itself. And that is what leads to these different developmental imbalances that we see. So I think it is very reproducible from a standpoint of that, we know that the right brain will, in general, if it develops appropriately, will do things. It's more involved with bottom up. It has a lot to do with, proprioception and feeling our body. And there is an overlap, as you said, with the parietal lobe, because the insula parietal vestibular cortex, the border of the insula and the parietal lobe is the primary vestibular cortex on the right side, which again helps us to develop a vestibular and sensory map as well as a somatic topic map. So it is reproducible, it is predictable, and so therefore we can use this to actually change things. But when this is altered in some way, that's where we see a problem. And it's almost always from a developmental perspective that this is altered.
So, I'm sorry, go ahead, Peter.
And what I was going to say, I think to Rob's point, one of the things we've seen over his career and what we've seen over my career is when you look at these kids, when you look at these developmental imbalances, there tends to be these almost like trademark symptoms that they have. That, when we look at autism, for example, we always see, for the majority of cases, if not all of them, underdevelopment in their GI system. Okay, so many of them have upregulated atopic presentations of eczema or skin rashes, or history of that, and then they tend to be a very overactive immune response. That when they do get sick, they get an immune response, and is it enough to knock down the infectious agent, or it lingers more and they don't get a contraction of their immune response? And so I think that's, and when you look at the laterality research, the research goes back 30 years. Unfortunately, the major brain laterality researcher for the immune system passed away several years ago from cancer. And unfortunately, not many people picked up his work. But, the basis of it was that, the left brain tends to be more the activator of the immune response, and the right brain tends to be more the inhibitor of that. And I think what we've seen over the years is that when you have a more dominant left cortical development, especially a progressively early onset of that left brain development, okay, are we seeing these higher instances of autoimmune types of presentations with these young children? And our experience has taught us is as we start to establish more right brain dominancy of the immune response, that we tend to bring that back in line. Now, there's definitely some nuances in that now, to where we look at the T cell positions a little bit different than we did maybe 20 years ago, and the simplicity of the T helper cell 1 and 2 and 3 and Th17. Now we know there's subsets, so there's definitely that has to be accounted for a little bit more in a way differently than we've done in the past. But I think that from a totality of what I've seen and what Rob's seen is that a lot of these kids tend to be classically more Th2 dominant or classically Th17 dominant. They don't have a very strong Th1 response or a natural killer cell response. And especially if their Th2 system is really revved up, they're going to have more autoimmune expression. And, one of the things that I've been teaching now that, Dr. Yannick's been talking about for quite a while now is the whole idea of like an increased Th22 expression, where you get, high level of glycation of antibody expression, so that they make the antibodies more stickier. And so then do we get a more, activation of these antibodies, especially in the basal ganglia that we may see in the PANS presentation. But I don't think the answer is just purely trying to promote a polarization shift. I think that's part of the answer, but the bigger thing is this top-down modulation of the immune response and trying to get that right brain to come online more, so we do get a more developed gastrointestinal system, so that every child that we treat doesn't have to stay on glutamine and dry licorice and all these products for years and years and years to try to treat their gut.
Yeah.
Because what is, if you're looking at this from like Rob's point of view and saying, okay, are we looking at this autonomic dysfunction, and are we looking at really more a heightened sympathetic response, and the fact that the parasympathetics seems to be more governed by the right side of the brain? Okay, so if we're shifting towards a left-sided early development, do we get increased sympathetic outflow? And obviously we're seeing that decreased parasympathetic aspect. So I think for us, I think our database is much different than most people. And I think that's why we can be probably very more convicted to say, listen, you fix the laterality, you address the laterality, you are going to address downstream neuroimmune consequences. And we do see children, do better with gut function and do have better overall intestinal function. They don't seem to get into intestinal inflammation quite as much. They don't seem to have to constantly be on guard for so much contamination to food responses because their system does finally calm down.
And is that the brain work that you're referencing there and the changes in gut health and function, is that with or in the absence of, say, nutraceuticals that are designed to get rid of infections or support healing permeability issues?
I think, from my approach has always been you kind of using those as you're modulating the immune response. You're trying to modulate that T cell polarization, and you're trying to maybe cut down on the gut inflammatory stuff while you're trying to build the brain. Okay. But as long as because if you do nothing but just do that, like most of the functional medicine world, we see it all the time. Their parents are walking in on supplement after supplement, and they haven't changed that immune response, or they haven't changed that gastrointestinal development because they haven't done the bottom-up development of the brain, and then getting that bottom-up interference out of the way, so that way now you can get those higher cortical networks to finally come on and do their inhibition and maturation of certain areas. And so I think that's the biggest thing is that, you do those, we use these T cell supplements and way we're trying to modulate the immune response, but to quote unquote get a more permanent effect, it's got to come down from the maturation of that right hemisphere.
I think a good practical example, Steve, is kind of jump on what Peter was saying before. Most of us know, we've all experienced where we go, oh my God, I feel like I'm getting sick. My throat starts to get a little thicker feeling, and I'm just not feeling great, right? And that leads to what we call sickness behavior. Any behavior, for us to be able to perceive that, it has to be happening in the brain.
Absolutely.
Right? We have to register that, where somewhere we go, oh, my throat doesn't feel good, and I know I'm getting sick. And so the immune system, and no one's ever really thought about that or really said, oh, well, okay, so we must be perceiving it in the brain. So then the brain is going to react some way. That's what it does, right? It feels things and then it reacts. And that's what Tracey's work was really, I think, really on the forefront of. But he still stayed kind of low down in the brain stem and the lower part of the brain, didn't really completely bring in, the upper part of the brain as much, like the orbital frontal cortex, which plays a role in that, and other things that play a role in it. But it's just for somebody to think about it, like, okay, your stomach doesn't feel good. Or you ever had a chance where you ate something and you just didn't feel right. And then, a few hours later, you were puking your brains out. But as soon as you ate it, you didn't feel right? Where did that, you perceived that somewhere. We have to perceive it in our brain. And where we perceive it is in that insula and in the homunculus. If we can localize it, it's in our homunculus. And then there's an efferent reaction to that. And there are pretty well-known pathways that we know that do all of that.
Rob, I'll direct this to you because I made the point when I was teaching in San Francisco that, there's so many cases, and I'm not talking about like kids on the spectrum right now, but just, generally across functional medicine clientele, that people come in and they have a leaky gut. They might have like an altered circadian rhythm, and we do some supplements, we make some lifestyle adjustments, and those things sort themselves out. And I made the point that whenever you are doing what you think you know to be right from a nutraceutical dietary lifestyle standpoint, and you get these resistant patterns, like you get the leaky gut that either never goes away or always comes back, or you get that abnormal circadian rhythm that just doesn't smooth itself out with the standard practices, I made the point, like, you've got to think about the brain in those circumstances. Would you agree, and how might you modify that sentiment?
Yeah, I think, from the very beginning, when I was down there in the DR and listening to these doctors, they both did a good job. And it really started with, there's this problem in the gut, and there's a leaky gut, and there's intestinal permeability, and there's a breakdown, and there's not the production of enzymes and acid, and that leads. But my question is, okay, well, why is there a leaky gut beyond a certain age? And why aren't they producing these acids and the enzymes? There's a step, and that's where I think it starts in the brainstem. The brainstem is not coming down from the beginning, and the gut starts out leaky and open, and the sympathetic nervous system is on full when we're born, and the parasympathetic nervous system isn't. So that's how we start life. And if somebody's still like that, where they still have a leaky gut, they still have a sympathetic dominance, they're not producing the parasympathetic, then it most likely starts in the brainstem, because that nuclei that would regulate those things, the nucleus ambiguous of the parasympathetic nervous system and the nucleus tractus solitarius, isn't developing to begin with, right? So it's not that happens to the gut. The gut just isn't maturing because the brainstem's not maturing. So right from the beginning, the idea that it starts from the gut and works up is false. It starts in the brainstem and affects down.
Yeah. So I'm sorry to interrupt. I just had two thoughts as you were going through that. Like, we know that babies are born with a leaky gut, and that goes away spontaneously as long as things develop. Do you?
But that's the key there, Steve.
Yeah, exactly. And so I don't know the answer to this, but at what neurodevelopmental stage does that newborn leaky gut resolve, if you know?
When the nucleus ambiguous comes fully online, right? It's a parasympathetic response. As we start to eat food, and as we start to have a need to digest food and absorb it, now we start the rest and digest system, which is the parasympathetic, which is the nucleus ambiguous. Before that, we have the rostral ventral lateral medullary nucleus, which is the sympathetic nervous system. And we have the dorsal motor nucleus of the vagus, which is what starts it all, right? But ultimately, the nucleus ambiguous is what causes the gut to close up. It's what produces or allows for the production of, by either inhibiting the sympathetic nervous system or activating the dorsal motor nucleus, where we're producing digestive enzymes and acid in the gut. So that's where it starts on the way down. And that doesn't happen if that isn't maturing, meaning a child's still eating food, but it's not just the eating of food that causes it to close up. Because if that was the case, then no one who's eating solid food would have a leaky gut, right? Because that's the point. So there's something other than that isn't developing, even though now we're eating solid food, but yet we're not closing up that gut. We're not producing the enzymes. We're not producing the acid, and we're not increasing the blood flow to the gut for absorption. And this is everything you see in kids with autism, and this is everything you see in most kids in the neurobehavioral spectrum, especially with the right hemisphere delays.
And
and I would add that, the relationship of the orbital frontal system to all that, one of the things that we constantly see is that they have suppressed the output of their orbital frontal function. And so, and as Rob was saying, this early development of that orbital anterior cingulate insular mechanisms that are happening in that first year, first 18 months of life, 36 months of life. And so I think that's, when we look at kids with autism, they don't smell. Okay. Most of them don't have any sense of smell. You hold up a canister and you ask them to sniff in, they don't sniff in. Parents will talk to you all the time that they don't relate. The ones that are even verbal, they don't talk about, smelling, mom's cookies, or come into the kitchen and say, hey, what's cooking today? That smells really good. Okay. So And then you look at the orbital frontal's relationship to self-regulation and being able to, again, modulate those internal visceral states of being. Okay, that again, we all get upset, or we all can get anxious. We all can get a sense of I want to go towards something very aggressively, but what hemisphere really begins to regulate all that is the right hemisphere, and more specifically, the right orbital frontal. And so, as Rob has been talking about, this idea of embodiment, attachment, and self-regulation, it's all coming from the right side. And so, I think that we're going to continue to probably find out not only is the right insular cortex a major player in the immune modulation, but I think we're also going to probably uncover that the orbital frontal area has a lot to do with this immune modulation as well.
And we can map this out from the bottom up. I mean, we can kind of go through that.
Yeah, let's do it,
Steve. Okay, so again, in the periphery, as Tracey talked about, we have these peripheral nerves that are in our tissue and sensing. We have an infection, we have inflammation, we have something going on. And just like we perceive pain, we perceive that there's inflammation going on. We perceive that, what's happening. We perceive the presence of these foreign invaders through the sensory neurons. And all of that afferent input really comes through the vagus nerve. There was a recent paper recently that showed that the use of probiotics had a direct relationship on activating the vagus nerve, right? So from there it goes up and it goes into the solitary nucleus in the medulla, in the brainstem, and from there, then there is a regulation of, like I said, the rostral ventral lateral medullary nucleus, which is the sympathetic, the dorsal motor nucleus, and the nucleus ambiguous, right? So from the NTS, it's going to go to those areas, and it's going to feed information to either activate the sympathetic or parasympathetic there. But then from the NTS, it goes into the parabrachial nucleus near the dorsal vagal complex. From the parabrachial nucleus, that goes to the paraventricular nucleus of the hypothalamus. And again, what they showed was with probiotics, when it activates the vagus nerve, that goes to the paraventricular nucleus and can cause a release of oxytocin and vasopressin. But also, that's the start of the HPA axis, which is an anti-inflammatory pathway. But then it goes up from there into the periaqueductal gray, and then it goes to the amygdala, and then it goes to the anterior cingulate, and then it goes to the insula and the orbital frontal cortex. And then from the orbital frontal cortex, ultimately will come down and generate much of the efferent control along with the insula. So we go up and we see that, as we said, this is called the central autonomic network. It's a network that's been mapped out. We know it exists. And that's also that parabrachial nucleus is also where we initiate sickness behavior in the brainstem. That's where it starts. So getting a fever. We have some people, some kids on the autism spectrum that when they get a fever, they start speaking.
Yeah.
I believe the reason why many kids don't speak is because the lack of that insula and interoception and proprioception and not having a map of their body and not having that drive to communicate. But it would be interesting because when they get sick and they have inflammation, it ultimately gets picked up through the parasympathetic nervous system in the vagus into the insula and the right insula, activating it. And now they feel their body better too, and they speak. And then that initiates the HPA axis, which is generating anti-inflammatory, and it's generating, the corticosterone, which is our own most powerful anti-inflammatory system. So that's the way this network works. And the left hemisphere is more activating through the insula of the sympathetic nervous system and the inflammatory, pro-inflammatory cytokines and pathways. where the right hemisphere and the right insula is more through the anti-inflammatory pathways. And that is the way we see it working right now.
Peter, on that last note with pro and anti-inflammatory systems, do we have it? Like, I remember back when I first heard about this brain immune connection, people were talking about like lesional studies where, for example, the one that sticks out in my mind is if you damage the cerebellum, you lose your natural killer cell population, for example. And I don't know if that's been borne out or if that was a theoretical model. But is it a circumstance where, going back to a very simplistic T helper cell model of Th1, Th2, Th3, for example, if the right brain, particularly right insular cortex, is anti-inflammatory and gives us tolerance, would we expect that part of the brain to have more control over Th2 systems, over regulatory T cells, for example?
I mean, I think we're still trying to dissect that all out, because again, I think that when we look at, for example, we know that the Th2 system with for a long time was considered like this anti-inflammatory system, but yet but when it's overactive, it can really be super inflammatory, right? It's driving more of these atopic presentations. It's driving more of these asthmatic aspects. Okay. And then in the presence of a real dominant Th2 response where you're pumping a lot of interleukin 4 out, okay, and then you're also pumping out IL-5, IL-13. If you get intestinal inflammation, you can pump out like TSLP and other interleukins that are going to even promote a greater shift of that Th2 system. And then from there, if in the presence of a bunch of IL-4 and TGF-beta, do we shift over to a Th9 expression, and that may drive more of a mucosal response. Okay, so I think that's where I'm at least trying to process through that a little bit. Okay, to kind of say, because the way I'm looking at it now is that a lot of these kids are coming in with more of a Th2 dominancy to begin with. Okay, so what's driving that Th2 dominancy that we see, where we have the asthma, we have the atopic presentations. Okay, we have the over responsiveness to seasonal allergens and stuff. So we tend to see that. And then, when you do have a higher level of a Th2 system, you're going to kind of basically stop autophagy and mitophagy in its tracks, and you're not even going to be able to promote as much of a Th1 response. And so now, do you get a bigger burden of this bacterial situation in the GI system, where now you're allowing that bacteria to go, and you got more gut dysbiosis. Maybe you're getting more viral load burdens that are going on, and then the more aspects you get, because the one thing that we're seeing with the T cells, it's not they can morph in and out. It's based on the cytokine presentation that they have, that they can be dumping. If IL-4 is really present, it's gonna shift that naive T cell to Th2. But if all of a sudden IL-6 comes floating along, IL-6 is going to shift it to a Th17 system. So I think that I don't want to be linear yet in that construct. I think that we still have to unravel that a little bit more to try to see now with how rapid, and again, the idea that it's not like your whole body is systematically Th2 dominant. You're having it in very localized specific areas. You could be needing a Th2 response in your nasopharynx, but in response to a fungi, you need a Th17 response in your GI system. Okay, but I think what we're looking at least is the perspective of, are we shifting to where those systems are too dominant, okay, too overexpressive? Now the question is, how is the brain not regulating those two systems? I think that's the bigger question for us now, is trying to figure out that we know that we can shift into a Th17 dominancy, we can shift into a Th2 dominancy, we can lose the integrity of our Th1 system, okay? we may not have enough of that T regulatory, that the TH3 that we used to call, but now it's really dominantly called T regulatory system. But we lose some of that integrity of that system to modulate. But I think for me, we're trying to figure out how to pull it back, but then at the same time, probably really relying on that right brain to come down and calm down the TH2 and the TH17 systems.
Yeah, I think that the way you describe that is that, you can have, remember, how do we know what's happening in the blood? We draw it out and we look at it outside the body. So typically we test blood not in the presence of the nervous system. And if we did, would we get completely different responses? But also, as Peter's saying, if you can have an infection or something happening in one area and then a different one in the other, and you need different immune responses, the immune system and the metabolic system usually isn't that specific. It's usually more of a globality. When you need specificity, you need the brain to regulate it. You need some sort of like somatotopic map in our brain, like a homunculus of our immune system that would say, okay, I'm perceiving this in my right shoulder and I need to do this there to the immune system. And the immune system and the brain can regulate the release of these cytokines so that it promotes more of a inflammatory response here, or maybe an anti-inflammatory response here, and that they're like neurotransmitters being released or being modulated by the brain, modulating the release of those cytokines, which is orchestrating what's happening in the T cell polarization and what they're doing and where they're going and all of that. So I think the fact that it may be that specific just speaks to more and more that the brain has to be taking the main role in.
So is the primary role of the brain in the neuroimmune axis, is it to assist in T cell polarization to shift the population of different types of cells, or is it to change the behavior of cells that are already there to make them more active or less active?
I think that's a great question. I think it's probably both, to be honest. I think that, you're trying to, because again, especially with these T cells now, I mean, we're finding out they're not static, right? They can change on a dime, and then they can, let's say you go from a naive T cell and you shift to a Th2 cell, and that effector cell relationship. But these effector cells over here can then change on a dime to another T cell position, right? Based on the climate of what's happening, and really, based on the signaling probably from the innate immune system and how antigen presenting cells is happening, and what is the co-activation that's happening there, and what toll-like receptor is presenting that relationship that changes the morphology of that T cell. But again, I think that, as Rob has said, is that I think the elegancy is going to be here, the idea of like how the brain is signaling down. And I think we're going to see some breakthroughs in how the brain is telling, because the innate immune system is giving the instructions to the adaptive immune system, right? And so we now, I think, are trying to look at what is the brain doing to the innate immune system. And I think Kevin Tracey was beginning to kind of, and his team there were beginning to put some of the understanding to, okay, what can happen with a certain macrophage, or what can happen to a certain neutrophil, or this whole classification of innate lymphoid cells that, have just been discovered over the last, say, 10 or 15 years, that we're barely beginning to understand what they do. Like we have innate immune lymphoid cell 1, 2, and 3. 1 tends to be associated with a Th1 system. Innate lymphoid cell 2 tends to be associated with Th2, and Th3 tends to be the innate lymphoid cell 3. So, I mean, that's a whole nother scenario now. So, again, I think that we're going to be starting to see where we're going to understand a little bit more of the way the brain is discretely instructing the cells of the innate system to do what they need to do, and then how they're going to go and then tell, okay, the T cell system to do what they have to do, or the B cell population to do. I think we're going to have a much clearer picture on that over the next couple of years.
Yeah, what you just raised, Steve, was really our primary question around
Yeah.
research right now. Is we've come to the same point. We're like, wait a second, okay, and nobody that we're aware of yet has really answered that question that you just asked, and it's really great that you got there because, again, you only because you have a lot of knowledge, you're at okay, yeah, so this, and so we don't know the answer to that yet, but that's where we want our research to go, and we think that's going to be really important information.
Right. So going back to what you were just sharing, Peter, about the different TH systems, like where we've been able to measure, for example, CD4, CD8 populations for decades, right? And then in the last, say, 5 to 7 years, we've had labs offering expanded T cell or lymphocyte subsets, but these are still populations of different types of cells, and they show us numbers, they don't show us function. And we have other labs that will show us cytokine levels. All of these are taken, as you said, Rob, from a blood sample, separate and removed from the moment-to-moment influence of local environmental signals and descending regulation from brainstem and, let's say, the orbital frontal cortex and the insular cortex. But on top of that, they're an amalgamation of all the different compartments of the body, right? And for example, if you're working with like an autistic kid with a gut problem, you would love to know what's happening immunologically in the gut, not just the cell populations, but their activity levels. And if we're dealing with an adult, say with Hashimoto's, we're trying to understand the immune system, we pull a blood sample and it doesn't show kind of a classic Th1 dominance that we tend to expect. Like we can't really make any conclusions about the thyroid and the Hashimoto's process from a sample of blood that shows the amalgamation of all the immune processes that we're able to measure, right? And so the more that I learn about immunology and now bringing the marine piece in, the less satisfied I am with those as clinical tools. Now that's...
I'm right
okay.
there.
I was going to say, that's my opinion. I'd love to hear yours.
This has been the discussion that Robert and I have been having for 3 to 4 years now. As I really dug into this deeper, my frustration with standardized labs that allow us to look at flow cytometry and look at because again we look at IL-6 for example, like IL-6 has to really be in an acute state to probably see it elevated. If we draw it. I mean, I know it's become popular and since COVID, and so many Func Med practitioners are going around. Run this through a standard LabCorp request, and but I can tell you, I mean, if you do, you're probably not going to see it. I think that the thing that I've seen more reliable has been number one, the clinical presentation of the case. Okay, and looking at what tends to seem to be, are the patients more Th2 dominant in their symptom presentation? Again, are we seeing that the history of atopic type of presentation? Are we seeing asthma? Are we seeing sinusitis, rhinitis kind of things, UTIs, those things that tend to be more of those classic Th2 dominancies. Periodically, you again, if they're in maybe an acute state, you'll probably see the eosinophils elevate, or you'll see the basophils elevate. Okay, and they'll start getting upwards of 4%, 5%. I mean, right now the research out there on mast cell testing. I mean, people talk about it, and I know there's a couple companies out there that are saying, they can look at mast cell activation and pinpoint it. Maybe they can, and maybe it's a useful test. But I just go based off the symptoms of what I perceive to be more of a mast cell type of activation, and start down regulating. Again, sometimes you'll see where in the Th17 shift there'll be really an acute Th17, so you'll see a high CRP that can indicate a Th17 shift, or you'll see an elevated neutrophil level that's gone up in the upper 60s, low 70s, where you can begin to say, okay, is this patient in a Th17 mediated immune response? Do you get, maybe their fibrogen level that's elevated? Do you see an elevated ferritin level that's elevated? Again, those classic acute phase reactants. But in a chronic case, you may not see all of that completely elevated. So I think for me, it's coming back to, trying and then trying to catch the interval of it too. I think that's the other big thing I've learned over time is that with lab testing, especially like with antibody testing. Okay, I think one of the, I think the brilliant, I like what seems to be what Vibrant's trying to do, and even Cyrex is trying to do. But to me, I think the problem with those two is that they're cost prohibitive to be able to try to catch the contraction and expansion of the antibodies.
Yeah, and it's a snapshot in time, and like you said, these are very dynamic environments, right? Very responsive to shifts and changes in those local environments, and it's like.
And they're just like you brought up with the autoimmune patient with the Hashimoto's. Okay, at least with TPO antibodies, right? That's a pretty, you can get that through a conventional lab and get a, fairly
Right.
inexpensive number, and you can serially it. You can look at that over a period of a 2-week, 30-day, 60-day window, whatever that window is, and be able to look at it more. And then again, the question has become like, if we're looking at it now more from the antibody glycation standpoint, is that you might have a low antibody level and it's out of range, but it's low, but yet it's a very aggressive response. Okay, as opposed to the person that has a high antibody level and maybe they're not having a lot of symptoms. So again, back to this shifting of the TH17 system into a more advanced, TH21 shift, you're going to get that response to where, now the antibodies are more, more glycated and they're more sticky. And so now they may be more, attacking that particular target tissue. And so I think, I think with labs, I get frustrated because I do, Dr. Rob and I get asked all the time, like, will you use this lab? Will you use that lab? And I'm like, I don't know yet. I'm not convinced that those labs are going to give me the clinical picture that a good case history is going to give me. And especially when working with, some of these children that, coming in right off the bat that at 2-3 years old, they already shifted to a Th2 dominancy, and we can see it pretty quickly. And so we start modulating that down with some of the supplements we're using. And then, as we're treating the brain more, and we can get around that pretty quickly.
Yeah. Rob, going back to the idea of neurodevelopment and progressive stages, would you go so far as to say that as the right brain comes online first, that it has a preferential influence over innate immunity, like neutrophils and monocytes and natural killer cells, for example? Or are we still in that place of we just don't know? Like we have suspicions, but nothing's truly mapped out with high detail yet.
I think the way it works, Steve, is that, from a bottom-up perspective, all of the, again, seeds of what will become areas of the brain start in the brainstem. And then they make their way up, right? And as the brain is developing, as the child is developing, and they make their way up into the brain. And we know that bottom-up development mostly favors right brain development, right? So, that's pretty clear. And so we mapped all of this out this way. And, I think that, so initially the brainstem, just like the vestibular spinal, the reticulospinal, some of these descending autonomic pathways start in the brainstem and make their way down. And I think at the lower level, we tend to have a bias towards being more sympathetic on both right and left. But then as we get this up, and then as it starts to come down, if we get that, that's when the brain becomes more in control and regulates it, and we get more. And just as you're describing, as we're describing this, Peter saying that the immune system is so responsive, there's no way it's going to be that responsive purely through metabolic reactions. It can only be directed by the brain. Only the brain is going to move with that much speed, right? So again, and that's why looking at these things, when we're looking at it outside of the brain, I've always been frustrated by lab work. I mean, I drew blood on every patient when I was first in practice over 30 years ago. And from the very beginning, the labs didn't always seem to jive. And then I've done as much food sensitivity testing as almost anybody. And again, it never seemed to always, like Peter would say, sometimes a level 1 would be more aggressive than a level 5. And then even with the, finger prick antibody tests, I think they're a good guideline, but they've never really jived for me. There's something missing. And Peter has this term that he would talk about that I think you learned from Sam. What was that term, Peter, where it was like kind of there's this certain response happening when it doesn't really fit the way you think it's going to fit?
Oh, I think I'm going to try to remember now what I termed it.
What I'm talking about, it's like you said there was this, I don't know, some sort of, it's like this anomalous effect. And now there's a name for it, right? Where, okay, when the blood work isn't looking the way we look and the response isn't the way we expect it to respond, so it falls onto this name.
Yeah, it'll pop in my head.
And I said to Peter from the beginning, I think that gap that we've made this name up is actually the brain and the nervous system that you're missing, right? When it doesn't work the way you don't think. And it's the same thing in the brain, when people argue about the whole, is there the right brain, left brain, because we don't see it on a QEEG that way or whatever. Same thing. In most of the imaging that we do, even in highest level research, it doesn't have the sensitivity to pick up some of these subtle little differences in brain activity that actually translate into big differences in behavior. And that's why we have to look at the behavior of the individual. We have to look at it knowing what research has told us about right and left brain, and then it fits. Same thing with the immune system. People were saying we have to look at the behavior, the sickness behavior or the lack of sickness behavior. Kids with autism, they don't get sick. And even when they are sick, when they have raging infections, they don't act like
they don't know it.
Yeah.
Right? How do you explain that? And then, like I said, when they do get sick, they may actually speak better. So, you have to be able to explain all of that. And I think that the lab testing and even brain testing at this point is not at that sensitivity, but that just because we can't measure it doesn't mean it doesn't exist.
Yeah, and to Rob's point too, I mean, one of the things I think the frustration with labs too is that are they making their labs even too sensitive, right? To where, that they are wanting you to use their services so much that they narrowing in their sensitivity a little bit more. So I think for me, we're trying to put together an immunological labs of what we can hang our hand on the most, okay, and say, all right, hey, we feel very, we run a vitamin D, okay, we can put a lot of stock in that, okay. If we can run like a CRP number, I think there's, some real stability in that, okay. So I think where you're trying to find stability markers, but I've run, panels where I've done TMB lymphocyte natural killer cell panels through Quest or LabCorp, and didn't come out to match the presentation that I thought was going to happen. And, and then you go over here and you might run, what Cyrix has developed with their cytokine panel, and the same thing. It just doesn't seem to match. So I think for me, I'm always trying to look at the clinical picture of the case and the symptomatology, and then do the best that I can with, some labs that I think are, not too over expensive that we can measure and then try to get a serial pattern of that relationship. And I think, for me and what I've taught in Robert's course over the last 3 to 4 years is that, just doing a simple CBC, because it's so simple to reproduce, okay, and kind of see the trends, and you can see just the trends of the eosinophils, or you can see the trends of the neutrophils and stuff. And then, if you see a lymphocyte panel lymphocyte number that comes up, all right, maybe I do need to run a TMB natural killer cell profile and see that. But I mean, I don't think we're trying to tell families that they got to run all these sophisticated labs to get that. I mean, that's not where we're at right now.
And
we're just not satisfied.
Yeah, and I would agree. I would agree more often than not, like a lymphocyte subset panel doesn't match my understanding of the clinical problem, and maybe the problem is with my understanding. But I've also found an issue with okay, so I have this pattern of whatever dominance or deficiency, and here's a set of recommended supplements to change that, and I have not often see that change within what I consider to be a reasonable period of time, even though I might see clinical progress, right? And so that's, for me, that's when I started to go, okay, really, where does this fit in my bag of tricks? And so I've de-emphasized all of those things.
And I think that's true. I think there's an element of, one, I always look at, one of the things I've talked to Rob about is that, sometimes, using just only a couple products might be giving us a chance to go vertical and be able to push the physiology enough. And then at the other times, also the idea of, how underdeveloped is the brain? And even in adults, adults obviously can have these dramatic hemispheric
Right.
imbalances. And again, if you feel confident that, hey, your clinical plan is from a metabolic or neuroimmunological level, solid on the immunological side of things, then probably the other equation of it is the neuro side of it. And we haven't dug deep enough into, looking at, retained primitive reflexes on these
Right.
adults, underdevelopment of these systems, these early systems of the brain that still are impacting the way their psychoneuroimmunology is working and their endocrinology. So,
do you guys have any time limits, or do you want to keep going?
I got another call at 6:30 my time, so I only have about another 20
Okay,
minutes.
so as always, I have more questions.
yeah, I got a few more minutes and then I got to run.
Okay,
and,
so are you guys okay to go? Because here's what I would like to do. I'd like to dive into the insular cortex. I'd like to talk to you guys about its functional organization, its network connections, how you might assess it, how you access it to change its behavior and its function. And then maybe talk about some cases that you guys have done. And obviously that's a much longer conversation than just 20 minutes. So are you guys okay with scheduling another one?
Mm-hmm.
Awesome.
Yeah.
That's awesome. Fun. Yeah. So I appreciate it, you guys. You are both a wealth of knowledge, and the whole point of the Func Med Nation is to share, learn, grow, and be inspired. And you guys are fitting the bill. So I appreciate your time.